So, when you have a nail bed injury, you need to assess what your injury is to. That will be nail plate, nail bed, pulp, and bone. So you examine the finger. You look at the nail plate itself. If there's a cut through it, where the cut is, does it extend into the normal skin on the front, the sides? Does it, how mobile is it? You need to think about fracture. You get an x-ray, you're assessing the nail plate. If the nail plate has avulsed out of the fold, the eponychial fold, you need to consider that there might be an underlying injury to the germinal matrix. That's the first sign. The other sign for nail bed injury is subungual hematoma. So that's blood underneath the nail plate. If you have more than 50% of the nail plate with an underlying hematoma, you need to be highly suspicious of a more significant nail bed injury. If it's under 50%, potentially the injury is small, therefore you may not require one. You get your x-ray. Things you're looking about is whether there's a fracture at the tip, the shaft, or involving the joint. If it's a pediatric or a children's nail bed injury and there's a fracture, it could also be through the physis, which is the growth plate. So you want an AP, a lateral, and an oblique. That's what we call 3 orthogonal views on an x-ray. And that will allow you to assess where the fracture is. If the fracture is at the very, very tip, often which it is, and it's crumbly, this is often what we call a tuft fracture. Then you have the shaft, and then you could have, a diffracture dislocation or a fracture through the physis, which is a femur fracture that occurs in children's cases. Now let's look at the parts of the nail bed and pulp that could be injured. So in terms of naming nomenclature of nail bed injuries, you need to know about the nail folds, the different parts of it. So you have the eponychial fold. I guess that's what they call the cuticle if you're getting a manicure. You have the paronychial folds, and then you have the hyponychium, which is the pulp side. So eponychium, paronychium, hyponychium. And then on the volar surface, the palmar surface of the finger, you have the pulp. You want to assess the matrix then itself. So the part that you can see is the sterile matrix. If you look at your own fingernail, there'll be a little white crescent at the base between the nail bed and the eponychial fold. That's the lunula. Then underneath your nail fold is the germinal matrix. So this cut is across the sterile matrix. Oftentimes cuts can go in this direction, cut with a knife when taking out an avocado seed or digging out burgers and the knife slips suddenly through the burger and you can cut obliquely. If a cut goes across the skin like this, you need to be suspicious that the cut goes into the germinal matrix. So you need to assess the germinal matrix actively. To do that, you can put a forceps or a skin hook underneath, reflect it back and look. If you need to, now you're going to need to do surgery to repair it because you know there was a cut. You can do what's called a Zadex incision. The Zadex incision, I think it's used typically for ingrown toenails, is an oblique cut here and here, reflect it back, then you reflect the skin back on the eponychial fold and you get good access. So that's a bit about how to approach a nail bed injury. Now we need to talk about how you're going to do your nail bed repair. So you need to select your sutures. I will typically use a dissolvable suture. Repeat. I would typically use a 5-0 vicryl repeat to do it. If the suture is the wound is under a lot of tension, I might repair the pulp tissue with a non-dissolvable suture, but I always do and I'm thinking it's high risk of infection, I might use a non-dissolvable suture, but I always do the nail bed itself with a dissolvable suture. For the purposes of teaching, I am going to use a dyed suture so that you can see it in the tutorial. So if you still have a nail plate on in your fingertip, the first thing you need to do is release the eponychial fold. So the way I do that, many ways to do it. So the eponychial fold and the paronychial fold. So on top of the nail, I would get my scissor, or tenotomies ideally, or Mitchell's trimmer, it depends on your set, and push the skin off of the nail plate. It has lots of little attachments that if you just take off the nail straight away, it will take it all with it and ruin the folds of the nail plate. So I, on top of the nail, into the skin, and I flick it off. Push, push, push. You then need to go underneath the nail plate, so on top of the hyponychium, underneath the nail plate, on top of the nail bed. You see the scissors hit the top of the nail plate underneath. You push them all the way to the back. It's a bit tough. You have to push a bit of force. And then my technique is just to open the scissor fully. And because I've released all the folds on the top of the nail plate, you see it ping up. You then get an artery clip or a needle holder. You start on one side, clip it, and then roll the needle holder away. And it just comes off nicely. When you get to one edge, then you have to peel up. All right. We'll talk about optimization of the surgical field, local anesthetic, tourniquets, etc. At the end, maybe we'll do it as a members only section. Got to be some perks to being a member, right? You can join below or subscribe to that via MedSync VT on YouTube. Now we need to talk about where we start. So when you're doing nail bed repairs, you don't start your suture on the matrix. You start on the pulp. If you need to do K-wires, this is the time to do it. So you do a good wash. You can see your fracture. I haven't got a fracture here. I can see the bone, and I've done an x-ray before, so I know I haven't got a fracture. But if you need to do a K-wire and there's a fracture here, you can do it under direct vision. You can fire it antegrade. So you need a double-ended K-wire. Fracture bone, distal fragment here, proximal fragment here. You fire the distal fragment here, through there, come out the end, and then fire it retrograde. Once you've reduced it, fire it retrograde back down the phalanx into the middle phalanx and do a check x-ray. Once you've done that, you then need to start your repair by stitching the pulp first, the pulp injury first to align the nail bed, and then you suture the nail bed itself. Tips for stitching injured fingertips or even skin grafts is you stitch from island to shore. If I suture this way, I'll show you what will happen. So this is from shore to island. This is not correct. And I'll show you why it's not correct. If you suture from shore to island, it's already happening now. When you pull the suture, you see how it pulls the fingertip off? If you haven't got any stabilization, or the bit that is fixed is fragile, you will literally just pull the fingertip off or pull the graft off. So we don't do this. We don't do this because this is bad practice. So what we do is stitch from island to shore. And you start on the nail bed itself. You take a good bite. Align the sides first. Again, I would use a dissolvable suture, such as Vicrorapide. I'm using this suture so you can see the suture material for the video. Pull, pull, and pull. Keep a short end and a long end. Same principles apply for wound closure. Forceps palmed. Needle holder parallel to the wound. Needle holder in between long and short. Push in the last session we talked about how to kind of make your maneuvers small and neat and economical. You just have to push the nylon suture like this. Or any suture. Again, I would normally use a dissolvable suture. Lay a square knot. Alternate their position. In the last live session we talked about the scissor technique. Cut. And go again. So you now need to do the remainder of the pulp injury. And that's a bit over here. Again, you suture from island to shore. So that you're pushing unstable into stable rather than pulling stable into unstable and potentially pulling off the tip or the skin graft. Push, place, rotate. Push, place, and rotate. It's going to become my saying. Push, place, and rotate. So nailbed injuries, really common in children because they often have their fingers in doors and somebody closes the door. So that's the paronychial folds and pulp injury repaired. Now we need to do the nailbed injury itself. So lots of options. You can do a continuous suture, you can do interrupted. Now, the key with this is that the nailbed itself is very thin. So on pulp skin, there's a lot of subcutaneous fat to get to tendon, to bone in the way. On the nailbed, as soon as you kind of go a millimeter in with the needle, you might have hit the bone. So using a small suture on a friable, thin substance. So I will often take my fingers out of the needle holder, like so, to give myself more range of movement. I'll put the scissor down so that you can really see this technique. So I'm like this, take my fingers out, and then I am just literally rotating the needle holder in my fingers. So doing nailbed repairs, this is a sterile matrix, saying that the nailbed is very thin. As soon as you go in, you usually hit the bone. So I palm the needle holder so I can just pivot it in my fingers. As soon as I touch it, I rotate. You don't want to force it, you want to follow the curve. That's what I'm doing. If you can do it in one, great. If you can't, if you watch my fingers here, I slide back with my ring and then my thumb. Put some counter pressure on the nail bed so when your suture's coming through, it doesn't rip. Follow the curve, don't force it through. Don't grab the tip, grab the body and pull it in a direction that will keep the finger attached. Put the needle somewhere where you can see it and pull. And so when you're tying your knots, again, same thing applies. If you put a lot of force into it, you'll just rip it. So push, place, and rotate. Surgeon's knot, but lay it down, push it down, push down the knot. Not too much force, otherwise it will just rip. This is not a strength competition. Push, place, and rotate. And just watch your knot get secure. Don't pull it aggressively. The nail bed is friable after trauma. Economy of movement. Bring everything into one hand. You cut and you place. We talked about the Seymour fracture through the growth plate in children. I'm just going to repeat this whilst we talk about other things. How would you manage that? There's two schools of thought. If it's displaced, you need to realign it. Introducing metalwork is a risk of infection, especially if it's a traumatic cause. But you've taken this case to theatre, you can do a very good debridement. You're going to give them post-operative antibiotics. You get one chance to get it right. You don't want to take children to theatre several times. So some will splint it, push, place, and rotate. Tie square knots. The single knot is the reef knot. The double throw is the surgeon's knot. So you can splint it heavily, but obviously there's a risk of displacement. The other option is to fire a K-wire axially through the finger. In terms of K-wire selection in children, I tend to use a 0.9mm K-wire, or in little fingers of smaller people, kind of maybe under the size of 5 foot in height, because they tend to have quite small, thin little finger bones. In adults, I tend to use a 1 or 1.1mm K-wire in fingertip injuries or phalangeal injuries. So this is a sterile matrix laceration. through the middle finger. There was no underlying fracture. It involved the paronychium. It did not involve the eponychium. It did not involve the hyponychium. I would typically use a dissolvable suture. I showed you an example, Vicrorapide. I would use a 5/0 Vicrorapide for this, using this dyed suture so you can just see the placement. The nail bed is very friable, so don't do anything under a lot of stress and tension. Let your needle body rotate through, and don't tie your knots too aggressively. Our good old trick here never fails. And then let's just talk about local anesthetic. So for this injury, I would do a ring block patient in an adult. That means they're awake. So to do a ring block, I would use, in this case, 1% lidocaine, 10 mils, and an orange or a Sterican, a really thin gauge needle. The patient's awake. I tend to start on the dorsum because it's less painful than going through the thick glabrous skin on the palm. I put a bleb in the skin here, so I go either straight down, or if I'm sitting on the side, just under, into the fat, not into the dermis. I inject a bleb. I will then proceed with the needle down the side to get to the volar side. Aspirate before you inject, because the digital artery is what you'll come across first, and the digital nerve. Then I inject. I withdraw that needle back through the hole. I then go vertically and come down here and inject, aspirate, and then I aspirate first, then I inject. That we usually get the nerves on the volar and the dorsum for the most part. Let that work for a minute, and then I turn over. It will still be a bit tender, but this is how I do my ring blocks in general. But after giving it a minute, it's far less painful to inject via the dorsum, the back of the hand, than it is to go straight into the volar space. And then there are two ways to do ring blocks on the volar side of the hand, also known as the palmar side. You can go straight down through the middle of the finger till you hit resistance. That will be the flexor tendon. Withdraw a little bit. I mean a little bit, so you stay within the flexor sheath. Inject. You should see the finger swell. It might flex a little bit, curl up, and the patient will feel something running down their finger. That's a flexor sheath block, and that will do the volar side. Alternatively, you can just go into subcutaneous fat, inject. I prefer to do it on the flexor sheath. That's my preference. It works very well for me. So that's how I do the ring block. Now for these cases, they do bleed a reasonable amount, especially if there's a fracture. So you also want to use a finger tourniquet. If you haven't got a finger tourniquet, you can make a finger tourniquet. How do we do that? You get a sterile glove. You cut a portion of it. You get an artery clip or a second needle holder, and you place that. This is a 2 people job, but I'm a solo surgeon on YouTube. You pull. In common pitfall, people put the clip this way. Don't do that, it'll get in your way. Put it on this way. And tourniquet is on. You need to note the tourniquet time. I give myself about 12 minutes to do a simple nail bed and 21 minutes to do a complex nail bed. Why? Don't know, but that's how it works, and it works very well for me. It's a reasonably quick procedure, but don't rush. Tourniquets, fingers haven't got any muscle in them, so they are ischemia tolerant, but they shouldn't take you more than half an hour, really. A simple nail bed, I think, should be done within 20 minutes, but you need to have a plan before you start. As we've discussed, to summarize, nail bed injuries are common. You need to assess Where the injury is, so you have the eponychium, which is the skin above the nail plate at the base of the cuticle, so people say. You have the paronychial folds, the paronychium on the sides, and the hyponychium underneath. Pulp side, the pulp tissue. And then underneath the nail plate, you have the sterile matrix, which is visible. That white bit in front of the eponychial fold is the lunula, and underneath the eponychial fold on a reflecting C shape is the germinal matrix. Cuts that go transverse across what you can see will be your sterile matrix. Cuts that go across into the eponychial fold you need to be suspicious are a germinal matrix, have a germinal matrix injury. Suspicion of a nail bed injury, nail plate is avulsed out, or subungual hematoma. Less than 50%, you can just get a needle, put it into the nail plate, twist till it pops and let the blood out. The injury is not likely to be significant enough to need to go have the nail plate removed. It can probably seal itself if you just leave it alone and dress it. But releasing the pressure by trephining, putting the needle in and making a hole, reduces the risk of necrosis and removes the medium for potential infection. Above 50% of a subungual hematoma or a clear injury, it needs a nail bed repair. Local anesthetic, finger tourniquet, dissolvable suture. This is my preference, about 5.0, in children maybe even a 6. If it's a really complex injury, really traumatic, really hard to get purchased, risk of infection is high, I might use non-dissolvable for the pulp side, paronychial folds, but dissolvable still for the sterile matrix. You stitch from island to shore, because if you stitch from shore to island, you'll pull the tip off as you pull the suture. Same thing for a skin graft, you stitch from graft to normal to stable skin, so that you stitch into normal and stabilize it. You start suturing nail bed injuries by starting on the pulp side, do the pulp side that lines the nail bed for you, and then you do the sterile matrix. In terms of economy of movement, the nail bed is very thin. You often hit the bone very quickly, so I like to palm my needle holder. I place it, I rotate it by just rotating the needle holder in my fingers. It's just this movement, rotation. Then I put if I show you, I rotate, I put my ring finger in, I put my thumb in, I unlock the ratchet. The other way of unlocking the ratchet is just to push your thenar eminence into it. So I'll show you that again. Palmed, push, that comes up. And the local anesthetic ring blocks we talked about. So into the dorsum subcutaneous space, go down the sides, give it a minute to work. On the volar side, I prefer to go straight into the flexor sheath and let it go down the finger. So that is your quick tutorial on nail bed injuries. If you got value out of this video, have a look at our other sessions on fingertip injuries, on access and tendon repairs, and we'll see you next time.